Hello. Got it. For those of you who have been here, I'm actually in the Gates Foundation. There's some really nice pictures behind me. Sorry I can't be there with you in person, but this is a super exciting seminar for me. I'm really honored to be able to have one of my colleagues and collaborators, George Renier, here joining us. And he's going to talk about the RAMS project into details. And this is such a perfect timing because we are, at the very end of the project, wrapping everything up, doing country-specific dissemination, and having a special theme issue that's being prepared and hopefully will come out soon in the Tropical Medicine and International Health Journal. And also, I'm so proud of the project to be able to have, a lot of really fascinating innovations included, focusing on the mobile phone surveys and leveraging that as a mobile mortality data collection tool. But before we get to that, let me talk to you a bit more about George. He's, I'd like to think a colleague, but also a friend. And you're not surprised to hear, he's an associate professor based in the London School, but of course he got his PhD in Penn in demography and sociology. And we have been collaborating on this one, but also continue to collaborate on, a project that's called Reach, which is to try to scale up erythromycin in West Africa to hopefully improve child survival as well. George is published extensively in the area of mortality, fertility, and has really broad research interest, especially in sub-Saharan Africa. So specifically, he does demography of sub-Saharan Africa, HIV/AIDS, human mortality, sexual behavior, households and family dynamics, demographic surveillance systems and surveillance methods, and record linkage techniques. So he's done quite a bit of work in the health and demographic surveillance sites as well, has a lot of field experiences. So really fascinating to hopefully be able to hear a bit more from his perspective about this really large project that's also super innovative and relevant for real life mortality estimation in low resource settings. Oh, I should also add before I let George start, which is this is the first session, I think, in this academic year from the population and health area of interest. So look forward to George, your talk. And before I give you the floor, and the most impressive things I've done with George so far is we actually went sandboarding together in in UAE, in Abu Dhabi. So I don't know, George, you're gonna maybe talk a bit about that, or maybe I can, like I said, the YouTube link in the chat. But anyway, over to you.
Thanks a lot, Lee, for that very kind introduction. And I must say, there's somewhere on YouTube, there is a video of us all sandboarding if you're really interested. But for today, I will stick to the presentation about the RAMS project, if you allow me. Is that okay? All right, so thanks a lot for the invite, Lee and colleagues, and hello everyone in Baltimore. So it's really my pleasure to give a presentation about the RAMS project, which stands for Rapid Mortality Mobile Phone Surveys, and it's a presentation that I do on behalf of a whole range of collaborators, and many of whom are actually at the Johns Hopkins School of Public Health, including Liu and her colleagues, Agbesi Amuzu, Bob Black, Diwakar, and so forth. So several colleagues from Johns Hopkins have actually contributed to this project. So let me try and flip through my slides here. Okay, so let me start off with a little bit of a background. We started off during thinking about this project in 2020, and that was right in the middle of the COVID-19 outbreak. And we quickly realized, so for the US and Europe and many other countries, there were all these dashboards with daily updates on statistics on the number of new infections, but also the number of deaths and so forth. And it became quickly very clear that there were a wide range of countries in the world where these kind of data were not available. And that puts them as a disadvantage because suddenly the evidence is no longer there to inform policy responses. And secondly, it also puts these countries in a weak position to claim, for example, the right share of vaccines if they can't demonstrate the impact of the epidemic in their respective countries. And so that's when we started thinking of possible alternative data sources that could be leveraged or could be used during periods of a lockdown, because that's the time that we started thinking about this. And so in first instance, we were thinking of adapting methods for collecting mortality data from traditional surveys and censuses, adapting these to be administered over a mobile phone, and pilot whether that was at all feasible, and whether, secondly, if it is feasible, whether this produces reasonable mortality estimates. And the advantage of a mobile phone survey versus a classical face-to-face survey is that they are feasible without in-person contact. Obviously, during an epidemic outbreak, that is highly relevant. But there may be other situations where that can be important. For example, episodes or in regions where that are characterized by armed conflict, for example. So there are a number of possible applications there, COVID being one, or epidemic outbreaks being one of them. And secondly, a mobile phone survey offers simpler logistics and lower costs, or comes at a lower cost than a classic face-to-face survey, which is typically a logistically very demanding enterprise. So there may be advantages for doing this type of surveys, these more light touch surveys, for other reasons as well. But the problem that we faced is we didn't know, is it acceptable to do this kind of surveys at all? What are sort of the methodological pitfalls? What are the mortality estimates that are generated by these mobile phone surveys plausible, yes or no, and so forth. Okay, so that were some of the questions that we were faced with, and we brought together. Oops, I don't want the video right now. There is a little video there. Thank you very. Oops, I don't want the video right now. So if you really want, you can look at the video later on, giving a bit a broader exposition of the background and rationale for the projects. So in December 2020, we finally got the green light from the Bill and Melinda Gates Foundation to start this work. As I mentioned, there is a broad range of partners involved, including Johns Hopkins, and fieldwork was proposed in 5 countries. Generally, our general approach was to adopt survey instruments from censuses and surveys, such as the DHS or the mixed surveys, and try and implement them with or without minor tweaks in a mobile phone survey modality. Typically, what we also did is we tried to do in each of those 5 countries a national survey and a smaller validation study, or a set of validation studies. Some countries had 2 or 3 different validation studies, all serving slightly different purposes. Unfortunately, I will not have the time to talk a lot about the validation studies today, but if you are interested, feel free to reach out to either Lee or myself, and we'd be more than happy to fill you in with those. For the national surveys, our default approach, because one of the big problems with mobile phone surveys revolves around sampling. For the national surveys, our approach typically revolved around random digit dialing, whereby you use the numbering structure that is in use in a particular country, and you fill that in using that format or that template for the mobile phone numbers that are in use in a country. You randomly dial numbers until you reach a respondent, see whether they're eligible. If they are eligible, are they interested in participating in the review, in the interview, and then conduct the interview if that's indeed the case. That's sort of the default. There were a number of other approaches that we've piloted or that we've used in some of the countries. In Mozambique, Agbesi Amuzu and his team used the ComSat platform as a sampling frame, as well as random digit dialing. So different approaches were used. Random digit dialing is typically the main method of sampling. And then once the strategy was developed for sampling, the interviews themselves were done by trained enumerators who did live interviews, just as a trained enumerator would do a live interview in a face-to-face survey. So in this context, these are called computer-assisted telephone interviews because the data are directly entered in tablets. Let me go over this. So this slide summarizes all the field work that we've done under the umbrella of the RAMS project. So as I said, 5 countries where we worked: Bangladesh, Burkina Faso, DRC, Malawi, and Mozambique. It lists the fieldwork dates, the basic sampling approach, the actual number of interviews conducted, and so forth. And the implementing institution who was responsible for the fieldwork. And then the second or the third column there on that table lists the specific validation studies that were done, or nested ad hoc studies that were done in each of these countries. Okay, so I will not dwell too much on these other studies in this presentation. So I'll skip the details here in this presentation as well. Okay, so but in total we completed over 90,000 mortality surveys in each of these 5 countries, and fieldwork started somewhere from the middle of 21, I believe, up until sometime in 2023. That's when the last country completed its fieldwork. Okay, so first addressing, so what I will do now in the remainder of the presentation, I will not try to be exhaustive. I will highlight a couple of different elements from the project and discuss those with you here today. I will reference a couple of other documents that you can have a look at if you're interested in other aspects of the project as well. So, but one of the things that I wanted to highlight here is the issue of acceptability and feasibility, because that was one of the first questions that the funders asked us and our advisory board asked us. Well, is it really acceptable to do an interview over the phone about mortality if the enumerators have never met the respondents? Yeah, is it possible to do this without building that rapport that a face-to-face interviewer can typically build in an interview setting? And so that's one thing that we tried to test formally. So we did a small randomized trial whereby we had 2 versions of the survey instruments, one on the mortality, on the topic of mortality, the questions about deceased siblings, deceased parents, and so forth, or the parents that are alive, parents that have passed away, siblings that are alive, siblings that have passed away. And then the alternative question, so that was sort of a model RAMS questionnaire, so to speak, and we compare that against a general socioeconomic survey that we've adopted from another survey program And we compared that in what is called a non-inferiority trial. So basically what we wanted to see is whether the primary outcome of interest was whether the cooperation rate of the respondents was the same in the RAM survey versus the socioeconomic survey. That was our primary outcome. We had a number of secondary outcomes, whether the respondents in sort of debriefing questions at the very end reported negative feelings or an intent to participate in future surveys and so forth. And the bottom line there is that there was no difference in any of the pre-specified outcomes between the RAM survey, the mortality survey versus the general survey about general socioeconomic attributes of the household. Negative feelings during the interview were also minimal, and if they were present, they were transitory. 3 participants accepted, we offered that, accepted an offer to speak to a clinical psychologist out of, I believe, 3,000 or so people that were approached. And none of the respondents required any follow-up thereafter. So our conclusion here was simply that a mortality survey is not inferior to a socioeconomic survey in terms of the cooperation rates of the respondents, the negative feelings that the survey may trigger, and so forth. So that was very encouraging and give us sort of a leeway to continue this work. Another element that came up very early on in the discussions with the scientific advisory board was the advice to keep the telephone interviews as short as possible. 20 minutes was considered to be the upper limit. We were encouraged to keep interviews shorter than that, and so forth. But of course, we all know that a typical survey, a typical face-to-face survey, takes a much longer time. And some of the instruments that we use for measuring mortality also take a significant amount of time to administer. So we really wanted to reassure ourselves to what extent that these existing guidelines to keep interviews very short were valid, and to what extent these were supported by empirical evidence. So again, we did 2,500 interviews. We randomly allocated respondents to interviews of different durations. And then for each of these 3 types of interviews, and what we did there in that trial was to verify whether data quality in terms of age heaping, for example, deteriorated in the longer survey, whether there was more item non-response in surveys of longer duration, and so forth. Again, we also looked at the cooperation rate, whether folks were more or less likely to cooperate and to complete the interview of different durations. And again, we could not find evidence that in this small trial, at least, we could not find any evidence that data quality is lower and cooperation rates are any lower in interviews that are, in this case, up to 30 minutes long. Okay, so again, that is encouraging, or that was encouraging news. Another big element or big concern with mobile phone surveys in general is sample selection bias. When we do a classical face-to-face survey, we try to ensure that our sample is representative, and there is a big effort in study design study design for surveys goes into the proper sampling design and so forth, oftentimes with enumerating entire areas before you actually sample households and then individuals within households and so forth. Of course, you don't have that amount of control with a telephone survey. So, and in addition, mobile phones are not universally owned. Yeah. In addition, mobile phone ownership in a lot of countries, and especially the countries where we were working, is highly correlated with socio-demographic background characteristics that are also correlated with the outcomes that we were interested in, right? So the illustration on the right here uses data from DHS that also contain information on mobile phone ownership. Each dot there that you see on that plot represents one survey. And what you see there is the distribution of the odds ratios for each of these attributes: urban, rural, place of residence, the age group of the respondent, educational attainment, and wealth index indicator. And what you can see there is that the odds ratio are consistently above 1 for all the surveys where information was collected on mobile phone ownership and the social demographic background characteristics, right? So people living in urban areas are the median value across all the surveys are 4 times more likely to own a mobile phone than people in rural areas. And the difference goes up to 16 times. Yeah. The same is for people in certain age groups, not the youngest, not the oldest, but sort of the 20-25-year-olds or the 25 to 35-year-olds are up about 2 times more likely to own the phone than people who are younger or older. People who are better educated are more likely to own the phone, and so forth, and so forth, and so forth. And of course, we haven't spoken yet about gender here, because the data come from women exclusively. We couldn't look at the gender difference. So mobile phone ownership is highly correlated with social demographic background characteristics, and these background characteristics are also correlated with mortality outcomes, and therefore our mortality estimates are likely to be biased. Okay. The question is, what can we do to alleviate that bias then? And there are a couple of different approaches. One is to do something a priori before you actually do the interview. And that's what you can do there is to try and impose quotas for predefined population strata. So you may want to ensure that you have the right representation of urban and rural residents in your interviewed sample. You may want to make sure that you have the right age distribution in your sample and so forth. Okay, so that's an a priori strategy for alleviating that bias. And then after the fact, you may still find that your sample is not balanced on a number of attributes. After the fact, you can use post-stratification weighting to ensure that your population is representative in terms of a key set of attributes like age, sex, place of residence, gender, and so forth. Okay, so the imposition of quotas and working with stratified samples is something that we did at the design phase. And the last one, the weighting, of course, is at the analysis stage. But we wanted to do some work to try and understand what this selection bias could be before we actually went into the field and before we actually did the rounds work. And again, we reverted to DHS data because the DHS these days oftentimes collects information on mobile phone ownership, as well as contains a lot of the mortality modules that we had adopted for use in the RAS project. So we could actually use the DHS data, compare mobile phone owners to the population as a whole, or mobile phone owners to people who don't own a mobile phone, estimate our mortality indicators and see to what extent these are biased, one. And secondly, if they are biased, can we use post-stratification weighting to correct for that bias? And so we did that exercise for 3 indicators. One is the under 5 mortality rate, estimated from birth and pregnancy histories. The second is a total fertility rate, also estimated from birth and pregnancy histories. And the third one for which we did this exercise is adult mortality estimates. I've labeled this here 45Q15. It's a probability of dying between age 15 and 60, and we demographers or epidemiologists estimate that from sibling survival histories. Sibling survival histories. Sorry, I don't know to what extent the audience is aware of all these instruments, Lee, but a birth history is a relatively short questionnaire whereby you ask women of reproductive age about all the children that she has had in her lifetime and to what extent these children have survived. If they died, you ask the details about the deaths. The sibling survival history is something very similar. You ask respondents about the number of siblings they've had, maternal siblings they have, and also the survival status of each of these siblings, and if they died, the details of these deaths and so forth. Okay, and we use that for estimating adult mortality. Okay, so let's go back to the exercise that we did with the under 5 mortality and the total fertility rate, see whether there is selection bias, and second, can we correct for the selection bias? And so on the left panel here, the 2 columns on the left are the under 5 mortality, and the 2 columns on the right are the TFR. So what do we see here is the unadjusted estimates. So these are the estimates that we get if we would rely on a sample of. Sorry? Yeah. Is everything okay?
Yes.
Yeah. So these are the estimates that you would get if you would rely on a subsample of individuals who own or have access to a mobile phone. And you see that most of the estimates are very close to the dotted line, which is a ratio of 1. And a ratio of 1 means that there is no difference in mortality estimates between mobile phone owners and non-owners, but they are a little bit to the left of that dotted line, so meaning that the estimates for mobile phone owners tend to be a little bit lower, right? And that's what you would expect, because people who own a mobile phone are typically better educated or richer, more likely to live in urban areas, and under 5 mortality is a little bit lower. So that's the raw data if you would rely on a subsample of mobile phone owners only. Once you adjust for the socio-demographic background characteristics that I mentioned, place of residence, age, and education and wealth, we see that the estimates shift in the direction of the dotted line in the middle, which means that we can actually correct our estimates produce estimates that are no longer biased. So that's good news. We do find that there is bias, but we also learn that we can easily correct for that bias where it exists. Then when it comes to TFR, the story is a little bit different. You see that the estimates are much further removed from the dotted line. So that's the 3rd column. So I'm referring to this column here. Oops, yeah, that's not working. I'm so referring to this column here. The estimates are further removed from the dotted line. And once we try to adjust for socio-demographic background characteristics, we can know the estimates shift a little bit in the direction of the dotted line. So that's good news, but they never reach the dotted line or in most of the countries, they never reach the dotted line. So the bias cannot be fully corrected there. Okay. This is another look at the same data. In the interest of time, I will skip the slides. This is the story about adult mortality estimates, a slightly different, it comes from a different paper, so slightly different way of presenting the results, but the analysis is in fact exactly the same. So what we do here is have estimates, it's distribution of estimates of adult mortality based on sibling survival histories from mobile phone owners versus the entire sample. So it's expressed as a ratio. And when the ratio is 1, as you see here for Burundi, the pink distribution here, and that line here is the median value for the distribution, is towards the left of that, the ratio 1, which means that there is a bias in the estimates of adult mortality, a downward bias in the estimates of adult mortality, if you would produce these estimates based on a subsample of mobile phone owners only. Okay, I see that there's some questions coming in, so perhaps we'll keep them for the end. Is that okay? Yeah. All right. But so for Burundi, we can see that there is a bias, but for many of the other countries, the pink distribution incorporates the ratio, the value of 1, meaning that bias is actually limited or even negligible. So in fact, in only 4 of the surveys, there was statistically significant bias. In 1 of the surveys, the bias was in fact upwards, so higher mortality for mobile phone owners, which is unexpected, but okay, these things happen. And then we tried the same as we did with the under 5 and the TFR. We see, okay, and what if we post-stratify or we weigh our estimates? Does that alleviate the bias? Yes, that's indeed the case, and that's represented by the green distributions here. In most cases, the bias is a bit smaller with the weighted estimates, but the correction is very small, and the correction, and that's more problematic, the correction is not always in the expected direction. So in this case, post-stratification weighting doesn't always help very much, and it may be even better to not weigh your data at all. Okay, so a couple more comments about this selection bias. The conclusion here from these analyses is that selection bias depends on the indicator of interest. And I think we need to distinguish between mortality indicators on the one hand and other indicators that are more volitional on the other hand. And within the subgroup of mortality indicators, we need to distinguish between indicators pertaining to co-resident household members of the respondents. So when we're doing estimating under 5 mortality, the mortality is estimated for children of mothers who are interviewed. So these children are co-residents. If that's the case, we should expect selection bias, and the selection bias can be corrected with post-stratification weighting on the respondent's attributes. When the mortality indicators are computed for relatives who do not necessarily co-reside with the respondents, so that's with the sibling survival histories, for example, because the respondent reports on their siblings, and the siblings may or may not co-reside with the respondent themselves. These siblings may live in an entirely different part of the country. And there we see that selection bias will be smaller or even negligible in most cases, but also that post-stratification weighting using the respondent's attributes will do little to correct bias. So if you really want to get a better handle on that bias, we need to also collect information on attributes of the siblings, not just of the respondents. Because household wealth, for example, of the sibling may not be the same as the household wealth of the respondents. Yeah. So there is some variability there depending on the indicator that you want to calculate. And then with regards to these other indicators, I mentioned TFR in the talk a couple of minutes ago, but there is also some colleagues at Johns Hopkins have done a study on estimating contraceptive prevalence of modern contraceptive use using mobile phone surveys. And they also found that mobile phone survey estimates were biased downwards. Now, as before, these data, TFR, contraceptive use, etc., these pertain to these are attributes or behaviors that are related to the respondents who reports that behavior, and selection bias should be expected. Now, the problem here is that these indicators like TFR and contraceptive use are not just an expression of one's living conditions, but also an expressions about one's, how should I say, put this, preferences, the preferences for having children. It's in a sense more volitional. Fertility and contraceptive use is behavior that is more volitional than mortality. One never chooses to die, or at least very luckily, very few people choose to die. Many people choose to have children, or you choose to have use modern contraceptive. And that element of choice, or that element of volition, is not captured simply by socio-demographic background characteristics. So if you want to weigh mobile phone survey estimates for these types of indicators that contain that element of volition, we need to use a different set of weighting variables. Okay, a different set of weighting variables that goes beyond socio-demographic background characteristics. And we didn't do that in this project because we were mostly focused on mortality indicators. Okay, so I just wanted to check what are we doing, how we are doing with time here.
Yeah, so we'll end at 1:20, but fantastic if you can leave us some time for Q&A. There's already a question in the chat, so I'm sure, people are super interested in asking additional questions.
Okay, all right, okay. All right, so what I've discussed so far were all preliminary. See whether it is feasible, what are sort of the methodological challenges that we might face, how we can work around some of these methodological challenges. And so the next couple of slides, I will present a few results on mortality estimates and see how these results compare to external estimates. Again, I'm not trying to do something too that is exhaustive here. I'm just focusing on a couple of RAM studies that I've been involved in, but Lee has done a lot of other work, and other colleagues at the other institutions have done other work that is not represented here, or at the very least underrepresented here. Okay, so keep that in mind. All right, so with regards to estimating under 5 mortality and perinatal mortality, I'm showing you here only data for Malawi. One of the studies that we did is, we used the DHS instrument, pregnancy histories. That's a new instrument that the DHS is currently using for estimating under 5 and perinatal mortality. Adapted that for a mobile phone survey method of administration, and see how the results compare to external estimates from the UNICEF and so forth. We tried different things here because you may remember initially when we started off with this project, there was this concern, but we need to keep this interviews as short as possible. We need short instruments, as few questions as possible, etc., etc. So one of the things that we tried is to truncate the number of questions that we asked women rather than administering a full pregnancy history. we also piloted a truncated pregnancy history, which is a reduced set of questions. The DHS has used them, or the DHS program has used them in the past as well. So we tried these different types of instruments to see which one works, or whether to, especially to understand whether truncated pregnancy histories work as well as full pregnancy histories. In this context, the issue with full pregnant, or one of the big differences between full pregnancy histories and truncated pregnancy histories is that full pregnancy histories are administered, the data is collected in chronological order. You ask women, what was your first pregnancy? What was the outcome of that first pregnancy? How old is the child now? And so forth. And you go to the second pregnancy and so forth. With truncated pregnancies, you can't do that. You have to work backwards in time. So you start with the most recent pregnancy, when the pregnancy started, when the pregnancy ended, and so forth. And then you go back in time until you reach a truncation point. Okay. And that's something that may cause differences in reliability of the data, whether they're organized in chronological or reverse chronological order. We also collected data on summary birth histories. I will not go into the details here right now, but of course, I'm happy to say more about that in the discussion if you need it. Okay, so these are some data for Malawi. We estimated neonatal mortality, infant mortality, and under 5 mortality using the RAMS data. So the truncated pregnancy histories are here in blue. The full pregnancy histories are in pink. So we randomized these instruments, right? And then produced the outputs. And then we compare that with the summary birth histories. Again, you may ignore it for now. We compare it with the DHS estimates and the UN IGMI estimates. So these are the estimates that are produced by UNICEF on a biannual basis, right? And it's sort of a reference standard for mortality estimates for children for all countries in the world, the UN IGMI. Okay, so, and they're shown on a time scale. The estimates are shown on a time scale to illustrate to which episode of time the estimates pertain. And there also, you have the point estimates. Here is the dotted line, and then the shaded area is the confidence interval, right? In this case, for infant mortality. So what do we see here is that our truncated pregnancy histories typically tend to produce estimates that are not statistically significant lower than the UN IGMI estimates, but suspiciously lower than the UN IGMI estimates. And that stands in contrast to the full pregnancy history. So these are the estimates in pink, the MPS full pregnancy history estimates. These are online, so the confidence bounds here overlap with UN IGMI. The confidence bounds also overlap with the DHS. So that gives us some confidence to claim that the full pregnancy history estimates for Malawi, at least, derived from the mobile phone surveys, are equivalent to those produced by the DHS and UN IGMI. And that is true for neonatal mortality. For neonatal mortality, we're even on the high side, it seems. Infant and child mortality were sort of on par with these external estimates. Post-stratification weighting, as we learned from so that's the last bullet point here, post-stratification weighting produces a small upwards adjustment, and that is also consistent with what we've learned from the exercise that we did with the DHS data that I've shown you a couple of slides ago. So that's under 5 mortality. For perinatal mortality, we have a similar lesson here. In here, the distinction between the truncated and full pregnancy history is not so large anymore. But generally speaking, I think in terms of our perinatal mortality estimates, they are similar to the UNAGME estimates. There is some disparity here for especially the truncated histories are a bit higher than UNAGME, but again, the full pregnancy histories are on par with the UNAGME estimates. So very encouraging. This is another one that is quite interesting. That's a colleague from Burkina Faso who did this work. So he did similar sets of estimates than the ones that I've shown you just now. But as you may know, Burkina Faso is a country where, especially in the north of the country, is characterized by armed insurgency since a few years now. What he wanted to understand is whether the mobile phone surveys can actually be used to collect better data for areas that are not accessible in a face-to-face survey due to the insecurity in the northern part of the region. And so what he did is he disaggregated the estimates for conflict-affected areas and areas without political conflict or violent conflict, and see how the mobile phone survey estimates compare to the DHS. And so for each survey, so the top panel here is the Demographic and Health Survey, the bottom panel is the mobile phone survey. He further disaggregated estimates for two periods, 2016 to 2019, and then 2020 to 2022 in gray. And so the DHS survey seemed to suggest that mortality declined a little bit over that time. Of course, this is not statistically significant, but no drastic changes in mortality over that period of time or that interval of time, according to the DHS. If we then look at the trend that is suggested by the mobile phone survey, it's quite different, right? So we have the data seem to suggest that in conflict-affected areas, mortality, in fact, increased rather than decreased. Again, our sample was not powered to detect subnational differences in mortality for 2 calendar years side by side. So we can't make too strong claims, but at least it's very suggestive that the DHS is simply not picking up mortality changes simply because it excluded enumeration areas that were excluded due to the armed conflict. And with a tool like a mobile phone survey, you may actually get a slightly different understanding of mortality trends, in this case, under 5 mortality in these areas. So in that sense, mobile phone surveys may in fact become quite useful to complement existing survey programs for hard to reach populations. All right, let me have a look at the time. Okay, so I'm gonna skip this one. So this is a couple of slides focusing on adult mortality using sibling survival estimates. I'm just gonna skip that. It's generally, the bottom line here is the results are generally encouraging. There are still a couple of outstanding methodological caveats. But I'm more than happy to share full papers with you if you're interested in this. The last couple of slides, I believe. Yeah. Let me discuss those. The last couple of slides are on old age mortality. So that's the probability of dying between ages 30 and 60 and 60 and 80. In surveys, we can measure that using questions about the survival status of the respondents' parents. Is your mother still alive? Is your father still alive? What's the age of your mother, father? And if they died, what are the ages and dates of death of your mother and father? Okay. using that data, we can then directly or indirectly estimate old age mortality. And that's interesting because these many populations in the world are aging. And that's not only restricted to high income countries, it's a phenomenon that characterizes many countries in the world. And a lot of people are the mortality profile of populations is also shifting to old age. So over time, there will be an increasing interest in understanding old age mortality in a broader range of countries than is currently the case. The problem is that there are very few data sources out there that provide direct empirical estimates of old age mortality. Okay, and the parental survival histories are one tool to try and do that. The big problem with parental survival histories is that it's very noisy data. It's very dirty data in the sense that there's lots of age heaping. There is ages are reported with big imprecision. And also, a lot of people don't know the ages of the parents, also, or don't know it precisely. The ages of death, they also don't know it precisely, or there is a portion that doesn't know these ages precisely. So you need to fix that, you need to address that at the analysis stage. And that has to be done using imputation methods and so forth. But it comes with considerable uncertainty, but it doesn't mean we shouldn't be exploring those data a bit further. So using the data on the survival status of the parents and the details of the parents, their ages of death, and so forth, we can estimate mortality. And then for these two countries, we estimated mortality, compared that estimate with the WPP, which is the World Population Prospects. Again, these are estimates that are published by a UN agency, in this case, not UNICEF, but the UN Population Division. And so the reference data that we use here from WPP are given with this solid blue line here. That's for men. The red blue line is for women. The RAMS estimates, we make a distinction between direct estimates and indirect estimates. If you've never heard of that distinction, you can just ignore it for now. But so these are the direct estimates is the one that is of greatest interest because these are the most recent estimates. They seem to be quite well aligned with the estimates from the WPP. That's quite encouraging. Seems to be also characterized in the years just after the COVID outbreak that there was an increase in mortality. But again, we're dealing with small samples. We cannot make this claim too strongly. But that's for Malawi. Oops. And here below we see the similar pattern for Burkina Faso. Okay, so the correspondence with this external data sources are fairly good, so quite encouraging. This is the oldest old, so to speak, so the probability of dying between ages 60 and 80 years old. Here we see that the mobile phone survey estimates are typically lower than the WPP estimates. And that is true for Malawi and it is true for Burkina Faso. Now, the big question here is which set of estimates are the best? And we don't know that. I think the jury is still out for the simple reason that the WPP estimates for very old adults are modeled estimates. They are not based on direct empirical data. They are based on model life tables and inferred, or sometimes even inferred from levels of child mortality rather than based on evidence of adult mortality directly. Okay, so we don't know. It could be that the survey data are not good. It could be that WPP is overestimating old age mortality in low-income countries. Okay, all right. So a couple of concluding remarks. So one of the big lessons that we've learned from this exercise is that mortality data collection via mobile phone survey is both acceptable and feasible. Sample selection bias is, if it exists, like in the under 5 mortality estimates, it seems in most cases we can correct that. In some cases, such as estimates of adult mortality and old age mortality, it may not even be necessary to correct it because the bias is relatively small and the tools that we currently have for correcting are not reliable. So it may be better to go with the raw estimates. So that's the second lesson. The third lesson is that our mortality estimates are in the most cases plausible, but there is certainly scope for further methodological refinements. There is still fine-tuning possible in the translation of these conventional instruments, face-to-face instruments, to a mobile phone survey environment. There is opportunities for developing more novel instruments, whereby we elicit information not just on the respondent and the immediate relatives of the respondent, but reference a broader range of relatives. So there's possibilities. There are a method called network survival method. Some folks are exploring that using in a face-to-face context, but they may be able to be transferred to a mobile phone survey too. Lee and some of her colleagues have done some work on the collection of proxy pregnancy histories, whereby the respondent does not only report information about the children she has had herself, but also about the children of a close confidant, whether it's a sister or a very close friend. And of course, these methods have advantages that you suddenly inflate the sample size dramatically and can estimate mortality using much smaller samples. And that, of course, has a big cost advantages. Okay, so that's just a couple of examples of novel instruments that should be piloted or further work should be done to elaborate on that. And then in terms of the applications for this mortality mobile phone surveys, the example from Burkina Faso that I mentioned earlier seems to suggest that they could be an ideal complement to existing surveys for accessing populations that are harder to reach. For example, in settings where there is violent conflict and the mobility of enumerators may be limited. But there are also other possible applications, because mobile phone surveys have simpler logistics, they're cheaper to administer, and in principle, once you've done it a couple of times, they're also faster to the turnaround time between data collection and data availability is much faster as well. So, I had a couple of slides here with further information if you would like. There's the website from the project if you're interested. There is much more information there. And we've also recently put together a report summarizing some of the key lessons, some of the ones that I dwelled on today, some of the ones that I haven't talked about, but summarizing some of the key lessons from the first 3 years of the project that we've worked on. So you're all encouraged, of course, to consult that document. So let me stop here, Lee, and sorry for taking so much time.
Thank you so much, George. It's such a, gigantic project that has spent 3-4 years and has so many different components and innovations. Definitely feel free to, check out these resources that George has shared, or maybe reach out to him or to me, to other colleagues who have been working on this. I also want to do a quick plug-in to say that some of the instruments that George has been mentioning, pregnancy versus full birth history, direct versus indirect estimates, or estimation are something I will be covering in my fourth quarter advanced demographic methods and public health course. In case you're interested to learn more about that, feel free to reach out. So let me open up the question and answer session. So Zakil, I see that you do have this question from a bit back. Do you want to come off mute and ask that directly?
Hi, can you hear me?
Yes.
Yeah, I wanted to ask two questions actually. I already entered in the chat. That one is about you talked about selection bias. First of all, it's a great presentation. It's a new methods, I must say. About the selection bias, we can see that there's a different selection. But how about the quality of internet, especially the mobile network in rural areas or hard to reach areas? How does it affect the quality of the survey? Firstly, secondly, is there any time of the call? If you call during the working hour or during any time where they are taking rest, is it affect the response rate? I have these two questions right now.
Yeah. Network coverage is a big issue, or can be a big issue. Thanks for these nice questions, Zakio. Network coverage can be an important issue. It's something we haven't looked at in detail. Of course, some of the sort of the work that we've done on sample selection bias focuses on the limitations of the sampling frame, owning a mobile phone versus not owning a mobile phone. But of course, there are other possible sources of selection that may sneak in. So you may have selective participation rates, selective refusals, for example. You may have selectivity in terms of network coverage and electricity availability in different regions and so forth. And so that's why I believe that, and some of this will be corrected for using the post stratification weighting procedures, and the fact that our estimates, for example, for under 5 mortality are so close to the UNIGMI estimate seems to suggest that this is feasible. But of course, it may not be the same in all countries, right? Network coverage is not the same in all countries. Refusal rates may not be the same in all countries. So certainly a point of attention. And then you had another question. Can you quickly? I've written it down. I can't read my own handwriting anymore. Sorry. Can you please come in and remind me what the question was?
Second question is about the timing of the call.
Yeah. That's also a good question. One of our colleagues, Jetro Banda, has done some work on that. And if I can't remember, the differences were not enormous, but I believe the completion rates were highest just after in the early evening. I should actually let me come back to you about this, because I may say something that is incorrect. Yeah. So I can follow up with you, Zakio, if you're interested. Another element that was important was the place from where people take the call, right? At home, or whether they're on the road or whether they're at workplace and so forth. So these were also very relevant for the completion incorporation rates.
Great. Thank you, George. Do you want to send your email in the chat just in case people have additional questions? I wish we can probably at least get one question from the room there, but I'm also aware that we're very close at the end of toward the end of the seminar, and there are probably people who are waiting outside of the room. So maybe, yes. Wonderful. So George has his email in the chat. For those of you who have additional questions that didn't get asked right now, please do feel free to reach out. And yes, we'll be hopefully pushing out a lot of papers from the project in the near future as well, additional papers. Please join me in thanking George for such a wonderful seminar, and thanks everyone for coming.
Wonderful. Let me thank you all as well. And for those who have just joined Johns Hopkins, enjoy your year at in Baltimore and learn a lot from me and our colleagues.
And colleagues like George, right? All right. Talk to everyone soon. Bye for now.
Bye-bye.